Pregnancy is a time of incredible joy and anticipation, a journey filled with hopes and dreams for the little one on the way. As you navigate this special time, your well-being and that of your baby become paramount. Amidst the excitement, it's important to be aware of potential health challenges that can arise during pregnancy. One such condition, pre-eclampsia, requires our attention and understanding. Pre-eclampsia is a serious pregnancy complication that demands attention and proactive care. Fortunately, with knowledge and timely action, you can significantly reduce your risk and ensure a healthier pregnancy journey for both you and your precious baby. Pre-eclampsia, also known as toxemia, is a condition that affects pregnant women, typically after 20 weeks of pregnancy or even shortly after delivery. It's characterized by high blood pressure, a significant health concern during pregnancy. But there's more to it than just elevated blood pressure. Pre-eclampsia also affects the kidneys, causing protein to leak into the urine. This leakage is a warning sign that your kidneys aren't functioning optimally. Pre-eclampsia can range from mild to severe and can develop suddenly or gradually over time. The tricky part is that it often doesn't come with noticeable symptoms, especially in its early stages. That's why regular prenatal checkups and open communication with your doctor are crucial. Hypertensive disorders of pregnancy constitute one of the leading causes of maternal and perinatal mortality worldwide. It has been estimated that pre-eclampsia complicates 2 to 8% of pregnancies globally. In Latin America and the Caribbean, hypertensive disorders are responsible for almost 26% of maternal deaths, whereas in Africa and Asia they contribute to 9% of deaths. Although maternal mortality is much lower in high-income countries than in developing countries, 16% of maternal deaths can be attributed to hypertensive disorders. In the United States, the rate of pre-eclampsia increased by 25% between 1987 and 2004. Moreover, in comparison with women giving birth in 1980, those giving birth in 2003 were at 6.7-fold increased risk of severe pre-eclampsia. Diagnostic criteria for pre-eclampsia include systolic blood pressure of 140 mmHg or more, or diastolic blood pressure of 90 mmHg or more on 2 occasions at least 4 hours apart after 20 weeks of gestation in a woman with a previously normal blood pressure. Systolic blood pressure of 160 mmHg or more, or diastolic blood pressure of 110 mmHg or more. Severe hypertension can be confirmed within a short interval, minutes, to facilitate timely antihypertensive therapy. Proteinuria of 300 mg or more per 24-hour urine collection, or this amount extrapolated from a timed collection, or protein-creatinine ratio of 0.3 mg/dl or more, or dipstick reading of 2+, used only if other quantitative methods not available. In the absence of proteinuria, new-onset hypertension with the new onset of any of the following. Pre-eclampsia can cause rare but serious complications including stroke, seizure, pleural effusion, fluid buildup in your chest, heart failure, reversible blindness, bleeding from your liver, postpartum hemorrhage, excessive bleeding after birth, lack of oxygen and nutrients, which can impair fetal growth, preterm birth, stillbirth. If placental abruption occurs, separation of the placenta from the uterine wall, which can lead to heavy bleeding in the mother and result in the infant's death. While any expectant mother can develop preeclampsia, certain factors can increase the likelihood. These risk factors include a previous history of preeclampsia, chronic high blood pressure, diabetes, kidney disease, and autoimmune disorders. Carrying multiples, being over 35 or under 18, and having a family history of preeclampsia can also elevate the risk. Symptoms of preeclampsia can be subtle, so it's essential to be vigilant and recognize any changes in your body. Keep a close eye out for severe headaches, vision changes like blurriness or sensitivity to light, sudden weight gain and swelling in your hands, feet, or face. If you experience any of these symptoms, especially if accompanied by nausea, vomiting, or upper abdominal pain, contact your healthcare provider immediately. The primary treatment for preeclampsia is either to deliver the baby or manage the condition until the best time to deliver the baby. This decision with your healthcare provider will depend on the severity of preeclampsia, the gestational age of your baby, and the overall health of you and your baby. If preeclampsia isn't severe, you may have frequent provider visits to monitor your blood pressure, any changes in signs or symptoms, and the health of your baby. You'll likely be asked to check your blood pressure daily at home. Severe preeclampsia requires that you be in the hospital to monitor your blood pressure and possible complications. Your healthcare provider will frequently monitor the growth and well-being of your baby. Medications to treat severe preeclampsia usually include antihypertensive drugs to lower blood pressure, anticonvulsant medication such as magnesium sulfate to prevent seizures, and corticosteroids to promote development of your baby's lungs before delivery. If you have preeclampsia that isn't severe, your healthcare provider may recommend delivery after 37 weeks. If you have severe preeclampsia, your healthcare provider will likely recommend delivery before 37 weeks, depending on the severity of complications and the health and readiness of the baby. The method of delivery, vaginal or cesarean, depends on the severity of disease, gestational age of the baby, and other considerations you would discuss with your healthcare provider. After delivery, you need to be closely monitored for high blood pressure and other signs of preeclampsia. Before you go home, you'll be instructed when to seek medical care if you have signs of postpartum preeclampsia, such as severe headaches, vision changes, severe belly pain, nausea, and vomiting. Subscribe to our channel for more health and wellness videos.